Sir, thank you.
Yeah, I am joining from the mobile. Actually, I am facing some issue with the laptop.
Mhm. So we're all set. I think now we can begin. Yeah. Good morning, everyone. Namaskaram, and a warm welcome on a very sunny morning in the month of March. And thank you all for joining for this very exclusive webinar series on clinical genetics. We finished two exciting episodes, and today is the third episode on this important topic of clinical genetics. These webinar series episodes have been very popular because we are trying to demystify the concept of genetics, adding the clinical application to it, and I'm sure you'll enjoy the session today as well. I'll now request our president, Dr. Sunkoj Bhaskar, to please take over proceedings. Over to you, sir.
Yeah, that's Sri Krishna. Thank you very much, and good morning, our distinguished guest, Dr. Yogesh Parekh, our Honorary Secretary General of IAP, and the distinguished faculty, Dr. Prajna Ranganath and Dr. Priya Ranganath, and all the participants. I sincerely welcome you all for this third episode of the webinar series on clinical genetics. And I thank you all for encouraging us by participating in a big number. We may not see them more on this Zoom link, but many of them are following our YouTube link. So this is the third episode, and the first one it was on cytogenetics and chromosomal disorders, and the second episode was on genes and genome single gene disorders. Today we are talking about decoding patterns of inheritance in our clinical practice by Dr. Priya Ranganath, followed by the genetic counseling based on the patterns of inheritance. It's a case-based interesting discussion by Dr. Prajna Ranganath. And with these few words, now I request Dr. Yogesh Parekh to say a few remarks about our webinar and about our faculty. And before that, I sincerely thank Dr. Prajna, who is a professor at the Department of Genetics at NIMS, which is a Center for Excellence for Genetics. And really, we are privileged about the institute. And I thank other faculty member, Dr. Priya Ranganath. There is some confusion between the names. I don't know whether they're sisters or cousins or, however, they are closely related to genetics. That's more important. So, with these few words, now I request Dr. Yogesh ji to give your introductory remarks about the webinar.
I'm audible?
Yes, sir.
1 second. I, I think now there is no echo.
You're
Hello,
audible.
I'm audible?
Yeah, you're visible and audible, sir.
Okay. So good morning, all respected seniors and dear colleagues and the esteemed distinguished guests on this and fellow pediatrician on this DIP platform. It is my honor and privilege to congratulate Dr. Sunkoj Bhaskar, Dr. Sridhar, and Dr. RSV and Dr. Priya. Uh, all have started something new because this genetics is a neglected area for many common pediatricians. Those who are interested in genetics, they are taking more interest. But here, our fellow pediatrician in our clinical residency days, we are not learning more about the genetics. We are skipping out for the genetics. So Dr. Sunkoj and the team, PATS, have taken the initiative to start this wonderful journey of this genetics learning. So, and I learned that every first Sunday you are hosting these events, and this is the third episode. So first of all, congratulations, and you have already recap about these two episodes last 2 months. So I think this is a mission of the Dr. Sunkoj and the team to empower the pediatrician with the knowledge and the skills necessary to tackle the whatever the genetics disorders we are facing in our day-to-day practice. So with this, I wish best wishes to all of you. And I think that also our genetics chapters in the IAP also doing excellent work, and they are also covering so many various topics in the clinical genetics, and they are coming with our genetics guidelines and so whatever the necessary for to learn about this genetics disorder. So I would like to express my thanks to all of you, and best wishes for the happy learnings and the sharing of the learning. Over to you, Dr. Sunkoj and the RSC team. Thank you. Dr. Sunkoj, you have to unmute. Mute, you are muted.
Thank you, Dr. Yogesh. Despite your busy schedule on Sunday morning, you had accepted our invitation to grace this occasion. On behalf of PATS, we sincerely thank you. And now I move to our convener of this entire webinar series, Professor Dr. Prajna Ranganath, to take over this third episode and conduct the program, madam. Over to you, madam.
Thank you, sir. So at the outset, I'd like to thank, I'd like to extend a warm welcome to all of you to this third episode of this webinar series on clinical genetics. And I'd also like to express my thanks to Dr. Sunkoj Bhaskar, sir, and the entire team of PATS for this opportunity and this wonderful initiative of having this webinar series on clinical genetics so that pediatricians can understand the basic concepts of clinical genetics and apply it in their day-to-day clinical practice. So before this, I also thank Dr. Yogesh Parikh, sir, for his encouraging words. And with that, I'll first take you through a quick recap of what has already been covered in the previous two sessions. So, as Sunkoj Bhaskar sir had mentioned, the first session was on cytogenetics and the chromosomal disorders, the various presentations and diagnosis of chromosomal disorders. And the second session in February was on single gene disorders, otherwise known as monogenic disorders, various presentations and tests, and the how we approach monogenic disorders. So today I will first begin with a quick recap of what we've already discussed in the previous sessions. So as you all know, genetic disorders can be broadly classified into three main types. You have the gross chromosomal anomalies, you have the chromosomal microdeletions and microduplications, and then we have the single gene disorders. So gross chromosomal anomalies are basically abnormalities or disorders which are caused by abnormalities of number, that is numerical abnormalities, or abnormalities of structure of chromosomes. So these structural abnormalities can include chromosomal translocations, they can include chromosomal inversions like pericentric or paracentric inversions, they can include deletions or duplications, ring chromosome, isochromosome, and so on. The numerical abnormalities are mainly the aneuploidies, of which trisomy 21 is probably the most common, followed by trisomy 13, 18, and others, and of course monosomy X, which is otherwise known as Turner syndrome. Moving on to the chromosomal microdeletions and microduplications, these are actually small deletions or duplications in the genome within chromosomes, which are not big enough to be picked up in a conventional cytogenetic test, that is in karyotyping, and they require something called molecular cytogenetic techniques for detection because they are too small to be appreciated under a regular light microscope. So therefore, they are called microdeletions and microduplications. So here again, you can have microdeletions and microduplications just about anywhere in the genome, But then there are some common syndromes which are known to be associated with these microdeletions. For example, 22q microdeletion, which causes Dijot syndrome, 15q microdeletion, which can cause Prader-Willi or Angelman syndrome, 7q microdeletion, which causes Williams syndrome, and so on. And then we have this third broad category of monogenic disorders, which are actually conditions caused by mutations within genes. So here, typically, we can have either substitution of one nucleotide by another, or a few nucleotides may be extra or missing. Sometimes exons of genes may be deleted or duplicated, but essentially the mutations are within individual genes, and the disorder happens because of that gene function being disrupted. So those are the ones we call monogenic disorders. Here, of course, we have so many, like literally 7,000 plus disorders are known, of which really common ones include beta thalassemia, sickle cell disease, Duchenne muscular dystrophy, spinal muscular atrophy, neurofibromatosis type 1, and so many others. So this is the scale of genomic variation. When we are talking about chromosomal abnormalities, usually the abnormality involves millions of bases. When we are talking about microdeletions, the size of the abnormality can vary from about, let's say, 1,000 to 10,000 bases to up to maybe 1 to 2 million bases. Whereas when you are talking about single gene disorders, usually it is at the level of individual nucleotides. One nucleotide may be substituted by another, or few nucleotides may be inserted or deleted. Certain other mechanisms are also known. So pedigree drawing is very important, and that is the first and foremost thing that you would do in genetics. When you're suspecting a genetic disorder, it is important to have a minimum 3-generation pedigree for every family with a suspected genetic disorder. This provides us important clues regarding the pattern of inheritance, which we'll be talking about in detail in today's session. And by drawing a good pedigree, we are able to identify the at-risk family members who require carrier testing, pre-symptomatic testing, prenatal testing, and so on, which also will be discussed in the counseling session. Tests for chromosomal anomalies would differ depending upon what you want to look at. If you want to look at gross chromosomal anomalies, numerical chromosomal anomalies, karyotyping would suffice. If you want to look at specific microdeletions or microduplications, you can go for targeted testing such as fluorescence in situ hybridization with probes corresponding to the region of interest, otherwise called FISH. Or you also have another technique called multiplex ligation dependent probe amplification, MLPA, which also has specific probes targeted for specific regions. So if you want to look for these specific microdeletions and microduplications, we use targeted techniques, molecular cytogenetic techniques, we call them, either FISH or MLPA. But if you want to look for microdeletions, microduplications across the genome, then we use this broad spectrum testing called chromosomal microarray. And monogenic disorders are caused by variants in genes, which could be single nucleotide variants, small insertions, deletions of a few nucleotides, or maybe variations at the splice sites. So these are literally caused by something like spelling mistakes. And so we have to go for a different set of investigations to identify these single gene disorders. These are the ones we call molecular genetic tests, of which the commonly used ones include Sanger sequencing, next generation sequencing based techniques, and MLPA. So Sanger sequencing is suitable when you're looking for specific mutations, when you want to look for mutations in small genes, or you already know which mutation is there in one of the family members and you want to test the other family members for that particular mutation only, then Sanger sequencing would be the test of choice. Common example being sickle cell anemia, where all patients have this common mutation. At the 20th position, A is substituted by D. And here we can simply do targeted Sanger sequencing of the HPP gene to identify this mutation. We don't need any advanced NGS-based techniques for this. Whereas if you're looking at large genes, if you want to sequence multiple genes or you want to look at the entire exome or entire genome, then we use NGS, that is next generation sequencing technology, and MLPA is used One for chromosomal copy number variations, that is microdeletions and microduplications, and two for detecting the large deletions or duplications, one or more exons within genes. Common example being spinal muscular atrophy, where about 95 to 98% of patients have a homozygous deletion involving exons 7 and 8 of the SMN1 gene. So MLPA would be the first line test of choice when you're suspecting SMA. And then also in the last class, we understood some basic terminology related to genetics, such as what is a transcript, what do we mean by a variant, what is zygosity, how do we classify variants. So, variants basically are nothing but a difference in the DNA sequence of an individual when compared to the reference genome sequence. Mutation was the conventional term which was used to refer to a permanent alteration in the nucleotide sequence of the genome of an organism. But now the term variant or variation is preferred, but quite often we do see people using these terms interchangeably. And also, it's very important to remember that all variants are not disease causing. Many variations are simply harmless, benign polymorphic variations, and only a few are actually disease causing variations. And we also understood what zygosity means. So, between the two copies of the gene, if only one copy has the variant, that variant is said to be present in heterozygous form. If the same variant is present on both copies of the gene, that is, both alleles have it, it is said to be homozygous. If the two copies of the same gene have two different mutations, the variants are said to be present in compound heterozygous form. And for X-linked disorders, where you have only one copy of the gene in a male individual, if the variant is there in that single copy in the male individual, that male individual is said to be hemizygous for the variant. So autosomal dominant disorders are caused by heterozygous variants. Autosomal recessive disorders are caused by homozygous or compound heterozygous variants. Carrier parents will be heterozygous for the variant, whereas X-linked disorders, affected males will be hemizygous for the variant, carrier females will be heterozygous for the variant. Lastly, classification of variants is done as per the guidelines of the American College of Medical Genetics and Genomics and the Association for Molecular Pathology, as per which the variants are broadly classified into five main types: pathogenic, likely pathogenic, variants of uncertain significance, likely benign and benign. And usually, if you get a pathogenic or a likely pathogenic variant which matches the patient's phenotype and which also conforms to the expected segregation pattern in the family, then that is taken as the disease-causing variant. Likely benign variants are usually ignored. They are not likely to be contributory to the disease phenotype. Variants of uncertain significance are the ones for which sufficient information is not available at the present time to classify them as either pathogenic or benign, and therefore it is said we just keep them under follow-up mainly in order to get more evidence over time to see whether the variant is pathogenic or not. So with that, I'll stop the recap and we'll move on to today's session. So I'm really happy to introduce Dr. Priya Ranganath. She is the first speaker for today, and she'll be taking us through the various patterns of inheritance, the Mendelian and the non-Mendelian patterns of inheritance. Dr. Priya is consultant medical geneticist at the Apollo Hospitals, Karnataka, and she's also adjunct faculty at KMC Manipal. She has a lot of these things to her credit. She has obtained certification from Harvard for cancer genomics and nucleic acid therapeutics. She did her DNB super specialty in medical genetics from our center, NIMS Hyderabad. Before that, she had done MS in obstetrics and gynecology from Mysore Medical College and Research Institute. She has over 10 years experience in the field of genetics. She's a reviewer for several important journals. She's also a life member of the SING and an executive member of the Special Interest Group for Prenatal Medicine and the Society of Fetal Medicine. She has over 20 paper publications, and she's also got several accolades to her credit, including she was a gold medalist in the DNB course in medical genetics for 21-22, and she also has won several prizes for her poster and paper presentations in various conferences. So I'm really happy to invite Priya today for this session. And over to you, Priya.
Thank you, ma'am. That was a very, very big introduction. And I really thank the IAP for giving me this opportunity to be a part of their program, and to Pragna ma'am for inviting me for the same. Quickly going on to my topic. Today, my topic is Mendel and beyond, decoding patterns of inheritance for clinical practice. Before I start, I just want to verify that my slides are visible and my voice is audible.
Yes, Priya. The slides are visible. Yeah. Maybe you can be a bit louder.
Yes, ma'am. I'll try to do that. Right. So let's go ahead, and this is the photo that you have already seen. So you have a cell, and within the cell you have the chromosomes, and when you open up this chromosomes you get the genes, and there you have the variation A, T, G, C, the nucleotides. When there is a change, when it goes to A to T or T to G, then it can cause diseases. So this is called a variation, and if it's a pathogenic variation, they are called disease-causing variants. Now, genetic disorders are broadly classified into three things. You have the chromosomal disorder, the monogenic disorder, and the multifactorial disorders. Mendelian inheritance or inheritance patterns are generally designed towards the monogenic disorders. It all started from here. Sir Gregor Mendel, he's an Austrian monk who experimented with pea plants. He used peas because they were easily available, they could reproduce quickly, and they showed obvious differences in traits. So he could find 3 or 4 traits that he could actually visualize very easily. And he understood and called this something called a factor. From there, the loss of inheritance was born. So they said each character is bound by something known as a factor. At that time, it was a factor. The terminology was not gene. Now we know it as genes, and they occurred in pairs. So it occurred in pairs, one inherited from each parent. Now you had 3 laws: the loss of dominance, the loss of segregation, and loss of independent assortment. The law of law of dominance said that individual genes can have different forms. These forms now we know from previous classes are called alleles. We discussed alleles in detail. So some of which are dominant, which exert their effect over others which are recessive. Then you have the law of segregation, that is during meiosis, alleles segregate from each other, with each gamete receiving one pair of allele from a allele at a locus. And then law of independent assortment. We'll see these, these are now very colloquial. Now we know these much better and we have interpreted it much better. Just wanted to cover some historical aspect. I'm not able to change my slides after that AI thinking. So I was just wondering what happened. Let me stop and reshare.
Your slides are visible, Priya. They are on the. Okay, you've stopped share again.
Yeah, but I'm not able to move from there. Let me just recheck.
No, but we could see your slides moving.
After there was an AI, some AI, this is AI enabled like that it said, and then I was unable to move my slides. So I'm just restarting the entire thing, just to be clear. So yeah, now it is moving, right. So when we look at the pattern of inheritance, we have 2 types of patterns of inheritance. Now this is called Mendelian pattern of inheritance, and then the non-Mendelian pattern of inheritance. Mendelian pattern are our classic and well-knowns like our autosomal dominant, autosomal recessive, X-linked recessive, X-linked dominant, and Y-linked. Whereas the non-Mendelian are those associated with genomic imprinting and UPD, repeat disorders, mosaicism, oligogenic inheritance, and mitochondrial inheritance. I will describe each of that and their characteristic features and how to identify them. So first, going on to Mendel. Now it started with a case, and we are all familiar with the terminologies of autosomal dominant disorder. So only one copy of abnormal gene is required to produce a phenotype. That is, a phenotype occurs in heterozygous mutations. So that is what is an autosomal dominant disorder. So here, a 16-year-old boy was referred in view of tall stature. We did take history. There was no history of vision abnormality except usage of spectacles. And there's no history of chest pain, palpitations, and fractures. So obviously the clinical suspicion was at Marfan syndrome. We did the Ghent scoring and it came up to 8. So all the features which we typically see in Marfan syndromes were present in the child. So this just to highlight how to look at various factors and identify from the pedigree whether it's autosomal dominant, recessive, and so on. So if you look at it, there's always a vertical pattern of inheritance. What do you mean by vertical pattern? That multiple generations, in generation 1, generation 2, generation 3, you have multiple individuals who are affected. Males and females are equally affected. Here you see that there is no differentiation between them. You also see a male to male transmission. This is very important to differentiate it between X-linked dominant disorder and autosomal dominant disorder. So in autosomal dominant disorder, we see a male to male transmission by individuals of both sexes. That is, you can have male to female, female to male, and so on. And every child, if you look at it, has an affected parent. This is in a classical autosomal dominant. However, there are variations to autosomal dominant, which I'll also cover. So with all this, we can have a diagnosis that this is an autosomal dominant disorder. There are multiple examples of autosomal dominant disorders. You have achondroplasia, Marfan syndrome, neurofibromatosis, osteogenesis imperfecta, tuberous sclerosis, Noonan syndrome, Ehlers-Danlos, FAPs, and most of the cancers actually, Waardenburg, Holt-Oram, Treacher-Collin, and so on. I think somewhere it's getting stuck whenever a new notification comes. So sorry about that. Give me a second, please.
What happened, Priya? You're not able to move your
I'm not
slides?
able to move my slides whenever there is a new notification. That's the problem. I'm so sorry about that. So some AI notifications are coming up, so that is making it a little difficult. So we don't have to worry too much about understanding which are autosomal dominant, recessive. We do know most of them, but if we are confused, we can go up to Omen and look at the inheritance pattern for that particular disease, and that gives us a clue of what type of inheritance that will have. Now, coming to autosomal dominant disorders, you have mechanisms and characteristic of autosomal dominant disorder. If you look at the characteristics of autosomal dominant disorder, they show something called as pleiotropy, reduced penetrance and variable expressivity, de novo mutations, and codominance. I will explain all of those. And then you have mechanisms of autosomal dominant disorders, which include haploinsufficiency, dominant negative, and gain of function. All these are going to be explained. So coming to pleiotropy. What does pleiotropy actually mean? Now, a single gene mutation can lead to multiple manifestations involving different organs. So if we go back to our first case of Marfan syndrome, we saw that it caused something related to the eye, it caused something related to the skeletal system, it caused something related to the heart. So all these together does not look that they're trait 1, trait B, trait C, but they all come from a single mutation. And this phenomena is known as pleiotropy. Okay, so aortic, somebody can have aortic dilatation, somebody can have mitral valve prolapse, lens dislocation, and arachnodactyly. So all this, so single locus is responsible for all these seemingly different or seemingly unrelated phenotypes. It's called a pleiotropy. The second concept was of non-penetrance. So what do you mean by penetrance? So when you look at the pedigree, it can get very confusing. So I told you one of the characteristic feature of autosomal dominant pedigree is that every affected individual will also have an affected parent. But here you can see that one individual here who inherits the disease does not develop the mutation. So he has either inherited from his father or mother, and the disorder has skipped a generation. So these type of non-penetrance we commonly see with cancers, hypercholesterolemia, lipid intake metabolisms, and others. Okay. Then you come to this is another classical finding of incomplete penetrance. So this is a case of split hand foot malformation syndrome. So here all the dots which are represented in generation 3, number 6 and number 8, say they are having the mutations, but they do not manifest with that disorder at all. So this is known as decreased penetrance. So whenever you're looking at penetrance, you're looking at the proportion of heterozygotes for a dominant gene who express the phenotype. So if there are 10 individuals who have the mutations and 5 of them express the phenotype of that mutation, then we take it as the penetrance is about 50%. That's how we calculate the penetrance. Now coming to a different terminology. So I told you 3 things: penetrance, variable expressivity, and pleiotrophy. So in variable expressivity, the variability of the severity, not about the organs and other things. So it's the severity of the disorder can vary among individuals with the same genotype within the same family. So this is classically seen in neurofibromatosis, Marfan, Drachocolin, and so on. So one person in the family can have just Lisch nodules and kephaloid spots, whereas another person can have optic glioma, learning disability, neurofibromatosis, all of the features, full-blown features of neurofibromatosis. So this phenomena is called the variable expressivity. So here you can see somebody with seizures, somebody with chagrin patch, somebody with just intellectual disability, and then somebody having all the 3 of it. So all these together contribute towards the variable expressivity associated with tuberous sclerosis. So just to bring this all together, which seem very related but can be confusing. So I always show my patients this, so it's easy for them visually to understand. So you have 5 individuals, individual 1, individual 3, individual 4. They having the manifestations of the disease, whereas individual 2 and 5, despite having the mutations, are not having the disease. So this is called incomplete penetrance. So 3 out of 5 comes to around 60%. So variable expressivity is somebody can have a very severe disease like 1, and then as you go down the line, you can see somebody can have very minimal symptoms of the disease. So this is 100% penetrant. That is, all of them are having some of the manifestation, some or the other manifestation, but the severity can vary, and that is known as expressivity. And then you can have incomplete penetrance and variable expressivity occurring together, which can complicate interpretations and diagnosis in many conditions. And then pleiotrophy is like you have this mutation and then this phenomena and this phenomena. So it is completely different for each person. So that is known as pleiotrophy. So coming to the next concept, which is autosomal dominant de novo or a new mutation. Now the alteration occurs in the sperm egg that made the affected individual, maybe from the first family member of the unaffected, and the recurrence risk for this is going to be very low. So what do you mean by new mutation? So this new mutation is a mistake that occurred at some point, either during birth, during gametogenesis, or it happened completely during meiosis for that particular individuals. So here, this particular individual is the one who got the new mutations, and then further down the line, he passed that mutations to various individuals within his family. So this is known as new mutation or de novo. A classical example is something that we give of achondroplasia, where you see that the family pedigree is like this. Nobody in the family is affected, and the child is first time affected with the disease. If you check the blood of both the parents, you will probably not be able to identify the mutation in both of them. That is why it's called a de novo, and it is coming newly in the child. Now, recurrence risk in such cases are very, very low. We call it less than 1%. That 1% risk is what we give for gonadal mosaicism. What do you mean by gonadal mosaicism? Gonadal mosaicism just means that the blood cells of the parent might not contain that mutation, but the ovary or the sperms may contain that mutation. And because that is a possibility, we have there is a possibility up to 1% that the child develops this mutation. Now, a question of homozygous achondroplasia. So we have seen this very commonly, that two people who are achondroplasia, they marry within each other. So when they have, there is a recurrence risk that goes very high. And you can also have a homozygous phenotype of an autosomal dominant disorder, which could have more severe manifestation than achondroplasia itself. So here you can have 25% of cases, you can have it as a prenatal onset achondroplasia with much severe manifestations. So this is the photo explaining that. So generally, if you have affected mother with achondroplasia and affected father with achondroplasia, you have the capital D denoting affected. So you could have one who is completely unaffected. You could have about 50% children who are having achondroplasia, and then you could have somebody with a severely affected achondroplasia. Then the concept of codominance comes. So codominance we rarely see in Mendelian disorders, except ABO blood group, where we commonly give that as a reference, where both alleles in a heterozygous individual are fully expressed. So if you have an AB phenotype, A is also expressed and B is also expressed. So the blood group is AB positive. So that is one of the examples of codominance. Now I told you, let's also do the mechanisms by which autosomal dominant disorder occurs. And in that, we generally see three things. The first one of it is haploinsufficiency. So what is this terminology of haploinsufficiency? Now, haploinsufficiency occurs when a single functional copy is not sufficient to maintain a function. That is, you know that we share two copies of a mistake, or we share two copies of a gene, one coming from the father, one coming from the mother. So if one copy is affected, that itself results in a disease, just like for autosomal dominant disorder. And this phenomena that this one copy affected will cause a disease is known as haploinsufficiencies. Whereas in autosomal recessive disorder, if one copy is affected, this does not cause a disease. So that is called a haplosufficient disorder, or there is haplosufficiency. So this is the difference between the two. Now, classical example we give is to the types of OI, or osteogenesis imperfecta. So here a null mutation so we have two chains, pro alpha 1, pro alpha 1, 2 chains, and pro alpha 2, 2 chains, isn't it? So one deletion or one affected chain will result in a assembly of chain where you have two alpha 1 and one alpha 2 chain. Now alpha 1, alpha 2 come together and they will form some collagen. So that's why it is not very severe, but the amount is only 50%, half the normal. So it results in a milder phenotype, which is known as type 1 OI. Now, this is opposed to something called a dominant negative effect, which also occurs in autosomal dominant disorder. Here, what happens is mutated copy of the protein not only loses its normal function, but it also goes and interferes with the wild type protein, that is the unaffected protein. So it leads to much severe disorder than what we generally see. If I explain with an example, it will become clear. Okay, so here dominant negative effect. What we see is here same in osteogenesis imperfecta, the severe forms of osteogenesis imperfecta. The pro alpha 1 is affected, but not only is it affected, it's not going away. It comes and interferes with the formation of the triple helix for the normal chains also. So this results in very severely low collagen, and that results in a more severe form of the disease. So if you look at the differences between haploinsufficiency and dominant negative, haploinsufficiency is a single functional copy of the gene is not sufficient to maintain function. Whereas if you look at the dominant negative effect, the mutation protein actually interferes with the function. So it has a more severe phenotype. There is reduced or insufficient protein levels, whereas here the mutant protein leads to abnormal complexes, so more severe disease. Mechanism is LOF, loss of function, whereas here it's probably a mutant protein antagonizing the protein activity. The severity can be mild to moderate, here more severe than what we generally see. A lot of examples are there like Marfan, hypercholesterolemia, OI for haploinsufficiency, whereas we see the dominant negative sometimes in dominant negative types of FBN, osteogenesis imperfecta, and cancers. And rescue by normal allele, so it's very important when we think of gene therapy techniques for it. So if you give the normal allele, haploinsufficient disorder can actually get corrected, whereas in the dominant negative, it's a much difficult thing to correct. Now coming to the last concept in autosomal dominant, and I'll recap once it's done, the gain of function mutation. So whenever there is a gain of function, there is a negative regulator of growth that gets formed. This happens in tyrosine kinase domain with association with achondroplasia. So here the gene acquires new enhanced abnormal function. So unlike loss of function, which reduces or decreases the activity, these type of disorder, which is the gain of function, often results in lot of protein being produced, overactive, uncontrolled novel proteins, which can result in the phenotype. Coming to next one, which is autosomal dominant sex limited. Here is limited to specific sex. Disorder or trait can skip generation, and this is very
Yeah, please unmute yourself.
Okay. The next set of disorders are autosomal recessive disorder. So in these autosomal recessive disorder, we see a horizontal pattern of inheritance. What do you mean by horizontal pattern? Is a single generation is affected along the line. Okay. And now whenever there is a notification or something goes off, sir, I think that the screen is getting stuck for me. I'm so sorry about that. So So here we see that there is single generation affected. Males and females are equally affected. Parents of the affected individuals are carriers, and this type of disorder is called autosomal recessive. Here, the recurrence risk in the siblings is about 25%. Now, many disorders fall under the autosomal recessive phenotypes, all types of inborn errors of metabolism, thalassemia, sickle cell anemia, cystic fibrosis, SMA, all of them fall. So here you can see that when there is both the mistake copy coming from the parents, the child is affected. Whereas if one copy comes, they call a carrier, and then we could also have unaffected children. Now, there is a concept of pseudodominance. Now, what happens here in autosomal recessive disorder is an affected parent, but this is not a lethal disorder, goes on and marries somebody who is a carrier for the same disorder, like cystic fibrosis. So the child could have this disorder almost 50% of the cases. So this is commonly seen in our population where consanguinity is very common. So there's increased consanguinity over general population and is often found between parents of a child with autosomal recessive disorder, and the condition appears to be dominant. It looks like dominant because 50% recurrence, but it's actually pseudo-dominant. Okay. Next concept is that of genetic heterogeneity. So in genetic heterogeneity, we generally see in non-syndromic hearing losses. So there are different genes causing hearing loss. So you could have one in chromosome 2, and this could be autosomal recessive disorder where both the copies of the gene are affected. And some other chromosomes, like here it is probably 7 or 8 or 9 chromosome, where both again mutations are there at the mother. Now, when both of them come together, all of their children will be normal. So here you have both parents with hearing loss, but all of their children is completely normal. This concept is known as locus heterogeneity because the child will always get one mutation from the father, one mutation from the mother. So he will always receive the first mutation in chromosome 2 from the father and another mutation from the mother. So this phenomena is called a locus heterogeneity, and the child is called a double heterozygote who is unaffected. This in contrast to something called as mutational heterogeneity. In this, different mutations occur at the same locus, which we saw already. So you have HBB gene, there's one mutation which is IVS15 and another mutation which is probably 619 base pair deletion. Both of them coming together then can cause thalassemia in the child. And here it is called as compound heterozygous, and this is also called allelic heterogeneity. Now look at this pedigree. Here you have males who are more often affected than females. Affected males are passing it on to all their daughters and none of their sons, right? So no male to male transmission. This is what I told you. And the affected males in the family are related to each other through a carrier female. So always the female is the carrier who goes on to give to the male. So these are classically seen in autosomal recessive disorders. Multiple examples of autosomal recessive disorders are then there. These are Duchenne muscular dystrophy, Becker's, hemophilias, G6PD, Leishmani's, Hunter's, Bruton's, and so on. So in an X-linked recessive disorder, is it possible where a female can have a disorder of DMD or a female can get affected? We can classically give this 5 scenarios where it is happening. So the affected male is having a daughter from a carrier female. So this results in an homozygous female. So that can be there. Skewed X inactivation, Turner syndrome, X autosome translocation, and also in AIS. So coming to the next concept here, for rare conditions, females are about 2 times more likely to be affected, may be lethal in males, but usually milder but variable in females. The males pass it on to all their daughters who will be affected and none to their sons, no male to male transmission. And sons and daughters of the affected female have 50% chance of being affected. This is similar to autosomal dominant. What differentiates it is the absence of male to male transmission. And that is what you're looking at is the X-linked disorders. So many of them are there. You have Rett syndrome, incontinentia pigmenti, Alport, X-linked hypophosphatemic rickets, Gold, Aicardi. Some of them have male lethality also, like incontinentia pigmenti, Golds, Aicardi. These can lead to male lethality. Now, quickly moving on to non-Mendelian patterns, which are actually so sorry, it's a little difficult to understand. The first one is imprinting and UPD. Now, imprinting occurs with something called as expression based on parent of origin effect. So what it says is if it is there in the father, then it can cause the disease, but mother, it might not cause the disease. Why this happens, we will see. This is an epigenetic phenomenon. So mistakes are not really in the sequence of the genes, but something that is switching it on and off externally. Now, these are regulated by something called DNA methylation, histone modification, and chromatin organizations. The expression of imprinting control genes or imprinted genes are controlled by something called imprint control regions. So here you can see there are imprint control regions. Now, if an imprint control region, ICR, is methylated, which is represented by the black dots, then that particular gene is not expressed. Whereas if it is unmethylated, like it is expressed in the circles which are hollow here, so that results in the expression of the protein. So here, this is maternally imprinted and paternally expressed disease. The genes are same, the sequence is same, but because there is an outside control of who amongst the mother and father is expressing it, these are called as parent of origin effect, and they're called imprinting disorders. So in humans, you have about 100 to 150 genes which are imprinted. This is an outlook of all the genes that are there, or imprinting gene clusters which are found in our chromosomes. Now, each cluster is controlled by an imprinting center, and that switches on and off based on parent. So all those that are shown in red are maternally expressed gene, and all those that are shown in green are the paternally expressed gene. So if it is switched on in the mother or switched on in the father, then you have the disease as manifested. So this is a little complicated where you have methylation. When a methyl comes and sits on the DNA, then that could cause a disease. You could have histone modification where you can tie tightly around a chromatin. So the DNA is not available to be expressed. So because it's tightly wound up, it's not going to be expressed. This is one way. And then there's something called histone ejection and chromatin remodeling that helps in sliding down of the chromatin and causing the expression. So this is the three ways where it controls. Now it's of a surprise to many of us when we learned it that this global imprinting or what happens gets resetted every time an embryo is born. So when you see the sperm or the egg, you could have some imprinting on the egg, but this gets reset, everything gets removed. There is a germline erasure of it, and then a new set of imprintings start becoming acquired, that is germline acquisition, and then it goes on to have the own sperm and egg cells within that particular embryo. So if you look at it, it happens in these two phases. So initially, the zygote is formed. After the zygote is formed, there's a complete erasure of all the imprints that are there. Then the paternally imprinted genes slowly start putting their methylations, and then maternally imprinted slowly start putting their methylation, and then there's a maintenance. Why is this important to understand? It's important to understand because of this resetting, the imprinting disorders generally are de novo in the sense that it is newly acquired within the embryo, because the imprints are always reset every time. And generally, these are not very commonly recurrent in the future pregnancies. So we have seen in statistics that there can be up to 1 in 2,000 recurrences, but that's very rare. So for practical purposes, imprinting disorders generally do not reoccur. So imprinting disorders generally deal with growth disturbances, metabolic endocrine disturbances, neurocognitive disorders, dysmorphisms, and others. Generally, the maternally expressed genes are the ones that restrict growth, and the paternally expressed ones are those that promote the growth. So you also see a very classical pattern for them. Multiple mechanisms is there. So here, normal imprinting pattern is one particular protein is expressed in the father and one in the mother. Whereas in the imprint region deletion, there is an imprinted gene that gets mutated. And because of this mutation, there is no expression of that particular imprint related gene. It could also happen because of uniparental disomy, where both the copies of that particular gene are inherited from the same parent, or it could also happen because of an epi mutation where imprint control region has a mutation by itself, which causes alteration in this switch. Now we know a lot of imprinting disorder. Common ones are our Beckwith-Pidman, Silver-Russell syndromes, and Angelman and the Prader-Willi syndromes. Coming to the next type, which is called a triplet nucleotide repeat disorder. Now, in our gene, we have multiple triplet nucleotides like CGG, CAG, CAA. These are repeated across a stretch of the chromosome. So it's CGG, 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 CGG. So, and multiple of such repeats are there, they're categorized. So if you have less than 55, nothing happens. Between 60 to 200, there's a pre-mutation. More than 200, there is a full mutation, so which happens in Fragile X. So these type of repeat disorders, again, don't follow Mendelian pattern of inheritance. This shows something called as anticipation. So here you are seeing a pedigree of a family with triplet repeat disorders. You see the repeats through the generation. In the first individual, in the first generation, they had 65 mutation coming into pre-mutational stage. That then goes on to increase 75, 80, and then 200 comes in, and 200, 200, and beyond. So many of them, as the generation progresses, the repeats increase in number, and this phenomena is called as anticipation. So in triplet repeat disorders, the repeats increase as they go through successive generation of replication, and because it increases, the later generation can have diseases, or they can even have a juvenile onset of an adult onset disease that happens in Huntington. So this is a very important phenomenon. Now here you're seeing a very important condition where you had in the first or second generation, you had diabetes and cataract. In the third generation, you had some weakness, cataract, palpitation, all that went undiagnosed. And finally, in the antenatal scan, you could diagnose arthrogryposis. So you can leave the answer in the comment box, which type of a triplet repeat disorder this is, and it will be fun to do that exercise. Coming to the next part, which is mosaicism. So we did speak a little bit of gonadal mosaicism, but here I want to explain this in a little bit more detail. So mosaicism is generally considered a post-zygotic event. So it is presence in an individual of more than 2 cell lines. So you have one which is normal and one which is abnormal. And these are genotypically distinct and derived in a single zygote. You can understand when you see this picture. So in the zygote and up to the birth, there are no mutations. Then an error or a meiosis occurs in a localized area. This commonly is seen with cancers, and that can then lead to disease. So this is how it happens there. But you can also see it in certain other disorders. Like here, you had a gonadal mosaicism. Here, both the parents are normal, but the child developed a mutation on his own. Because he developed the mutation later, only few of his cell lines got affected. And because only few of the cell lines got affected, this is distributed in varying patterns of the body. So the phenotype of this child is going to be mild. So what is easily understood or known is, of course, it's not a Mendelian disorder, is for Down syndrome. In Down syndrome, you see a lot of mosaicism. There you understand there are 2 cell lines, where you have one which is completely normal and one which is having the Down syndrome. Now, the same phenomena can also occur in monogenic disorders, and this results in mosaic disorders. Now, you have one where the mosaicism has developed in the father here in the gonadal tissue alone, and because it has developed in the gonadal tissue alone, the child could still be affected. That's why when we go back, and I told you the recurrence risk we give about 1% for autosomal dominant disorders, which are de novo, is because that 1% could come from the parent. So this is for autosomal dominant disorder, de novo with gonadal mosaicism. Coming to a concept of oligogenic inheritance. So here they require more than one mutation in a single gene to express. So one gene is the predominant gene, other is a modifier gene, and a syngenic action of these two genes cause the disease. Here you will understand. So you have a variant A and a variant B. Only when both these mistakes come together into separate genes, the disease is caused, which is characterized by the pink circle. Whereas there is also a modifier plus effect that can happen. This is commonly seen in Bardet-Biedl syndrome and others, where you see this type of phenomenon. Last, we are looking at mitochondrial genetics. Here, they have maternal inheritance because the entire mitochondria comes from the egg. The mitochondria itself has a unique genetic code. We see something called the phenomena of replicative segregation, homoplasmy and heteroplasmy. I'll show that in the next slide. They have a high mutational rate because mitochondria is always multiplying, and there's a threshold phenotype in the sense that you see here the red ones are the normal mitochondria, and the green one is the abnormal mitochondria, a mutated mitochondria. So as long as the number of mutated mitochondria is low, it doesn't cause disease at all. But when you have, after a threshold, an increase in percentage of these abnormal mitochondria, that's when the disease happens. So that's why in Lay's disease, we see that threshold effect. So here you can think about it like a bottle phenomena. So in a bottle with a narrow mouth, so mitochondria are just poured in from the maternal oocytes. So if you could get one mistake, two mistakes, all no mistakes, one or two mistakes like this. So you could have something like this where you could have some disease, whereas in the second one, absolutely no disease. In the third one, there is some disease but no phenotype because it's relatively mild, and so on and so forth. So this is very important when it comes to pregnancy because you have to determine whether there is a homoplasmy or a heteroplasmy to understand whether the phenotype will exhibit or not. So this is one showing the same phenomena where you see the bottleneck effect because only one abnormal mitochondria is there. One normal mitochondria is there and multiple mutant mitochondria are there. This is 80% mutant. So child will be very severe. Whereas if it is coming from a different section from the mother's cell, you could have much lesser mutant mitochondria, so milder disease. And somebody with a child who's not getting the mutant mitochondria from the mother could have no disease. Coming to homoplasmy and heteroplasmy. Homoplasmy is when the cell contains only wild type mitochondria or only mutant mitochondria. So they are all in the same way. Whereas heteroplasmy will have a combination of a wild type and a mutant type. So the percentage of this heteroplasmy determines the threshold effect, determines the phenotype in the child. And mitochondrial disease, as we know, they are extensively distributed, can affect the heart, the eye, the liver, the kidney, and so on. And there are multiple effects of multiple examples of mitochondrial disease. Classic one being Lay, but we also know those which are then caused by nuclear mitochondrial genes and those that are actually caused by disorders involving the mitochondrial genome. So thank you for letting me have this presentation. I hope I was able to concisely tell you different points, and I thank the IAP and Pragna ma'am once again for giving me this opportunity. And sorry for the little bit of glitches while changing the slide.
Thank you, Priya, for that extensive explanation about the patterns of inheritance, the Mendelian and the non-Mendelian patterns of inheritance. I think you made it very clear to the audience about various principles and when we should suspect these different patterns based on the pedigree. So do we have time for the next presentation since it's already 10:10?
Good, madam. I know you'll complete the sort of time. We'll go ahead.
Thank you, sir.
If you are comfortable.
Okay, sir. So, Dr. Priya has already covered the various patterns of inheritance and the principles related to those patterns of inheritance. So, in my talk, I'll just be taking you through some clinical scenarios which highlight the importance of understanding these patterns of inheritance for appropriate and accurate genetic counseling. So, genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. And it is essentially a non directive process of communication. The doctor or the counselor does not tell the family or the patient that this is what you need to do, this is how you should proceed. Rather, after completing the evaluation and diagnosis, education is provided to the individual, to the family about the inheritance pattern, the course of the disorder, the prognosis, the management options, the recurrence risks, and based on all of this, the family and the individual then make informed choices of their own and see how they're able to adapt in the best possible way to the condition. So, always first we begin by determining why the patient or the family is seeking genetic counseling. What is the purpose? Have they come to understand the management options, the recurrence risks, the reproductive options, the pre-symptomatic testing options? So, each family may have their own expectations of a genetic counseling session. So, before we begin, we ask them what is the main purpose for the consultation, and of course, the process remains the same. We always begin with the detailed history of presenting complaints, including antenatal, perinatal, neonatal events, developmental milestones, associated systemic symptoms, and drawing the pedigree, the minimum pre-generation pedigree with all the relevant clinical details is absolutely essential because that gives us very important clues to the patterns of inheritance and further to the diagnosis. Also, we have to assess and record all the previous lab reports and available medical information, not only of the index case we call the proband, but also of all the other affected family members. Of course, this is followed by a detailed examination of the proband, which includes anthropometry, dysmorphology evaluation, systemic examination. Wherever possible, the parents of the proband and other available family members are examined. Further, all the relevant imaging studies and lab investigations are done. Based on all of this, we come to a specific set of differential diagnosis. Further, appropriate genetic investigations are done to confirm the exact clinical diagnosis and establish the exact genetic basis. So, confirmation of the diagnosis through genetic testing is always the first step. And thereafter, once we have the clear diagnosis established, counseling is provided regarding the genetic basis of the disorder, the course of the disease, the prognosis, the associated complications, management plan and follow up, the availability of disease specific therapies, if any, pattern of inheritance, risk of recurrence and subsequent offspring. What are the reproductive options available to the family, including the options of prenatal or pre implantation genetic testing, whether any patient support groups are available to where they can go and enroll, and also the possibility of enrollment into therapeutic trials is discussed. So, with that background, I'll now take you through some clinical scenarios which illustrate the importance of understanding the pattern of inheritance in order to do appropriate genetic counseling. So, this is the first case where we had this 4-year-old male child who presented with short stature, multiple skin pigmentary lesions, scoliosis, mild developmental delay was there. There was history of 2 episodes of seizures. History of similar skin lesions were there in the mother and the grandmother, and the mother was in fact referred for prenatal testing of the second pregnancy. Now, this is the pedigree. As you can see here, 3 generations are affected consecutively. Both male and female individuals are affected. So here, based on this pedigree, the pattern of inheritance is most likely sorry, autosomal dominant pattern of inheritance. So we examined the mother and the grandmother also. You can see the multiple skin lesions suggestive of neurofibromas in the grandmother. And the mother also had some of these neurofibromatosis lesions along with the cafe au lait patches. So here, based on the clinical findings itself, we have a clinical diagnosis of neurofibromatosis type 1. We all know that NF1 has significant variable expressivity. Dr. Priya already mentioned that many autosomal dominant disorders, particularly, show variable expressivity where you can have a lot of intra as well as interfamilial variability Intrafamilial means within the same family, affected individuals can have a great deal of variability in the age of onset of manifestations, in the severity of manifestations, in the pattern of manifestations. So, if the family really wishes to opt for prenatal testing, we have to identify the exact mutation in the NF1 gene. So, for this, the proband's testing was done. Because this is a large gene, the next generation sequencing technique is preferred. So that was NGS based NF1 sequencing was done, and we were able to identify the heterozygous pathogenic variant in the NF1 gene. Because this is an autosomal dominant disorder, we expect the mutation to be heterozygous. Between the two copies of the gene, only one is expected to have the mutation or the pathogenic variant. And now that we have confirmed that it is NF1, we know that this has an autosomal dominant pattern of inheritance. We know that the disorder may be transmitted to offspring of either sex. And because the mother is affected, the risk of recurrence in each offspring is 50%. So, because we have the mutation identified, we can do appropriate, accurate prenatal genetic testing through either chorionic villus sampling or amniocentesis and targeted mutation analysis of the identified variant in the fetal DNA. Of course, some families may not want to go for prenatal testing for NF1 because NF1 is a fairly common disorder. Many individuals have neurofibromas and cafe au lait spots but don't have any other complications. But we do know that, as I said, there is a lot of intrafamilial variability. So even if the grandmother and the mother have had only the skin lesions, the subsequent generations, they could have additional major complications, including sometimes malignancies and other associated optic gliomas and other problems. So, after detailed counseling, the family opted for prenatal testing. Again, we have to tell them that prenatal testing will tell us whether the fetus is affected or not, but prenatal testing cannot predict the severity of manifestations. Having understood all this, the couple decided to go ahead with the prenatal testing through amniocentesis. Targeted Sanger sequencing was done in the fetal DNA for the NF1 mutation, which was already identified in the proband. Unfortunately, the fetus was found to be heterozygous for the NF1 mutation, hence affected. Again, post-test counseling was done that postnatal severity cannot be accurately predicted. The exact, although all the skin lesions are universally expected, but the other complications may or may not be there in the affected child, but the family opted for discontinuation of the pregnancy. And of course, now that we know that this family has NF1 and multiple family members are affected, surveillance for anticipated complications has to be advised or counseled for all the affected family members, which includes a 3 monthly BP monitoring, 6 monthly evaluation for all the expected skin, skeletal deformities, neurological deficits, etc. Annual ophthalmology evaluation has to be done. If there are any neurological deficits, we may have to do neuroimaging of the brain and spine and so on. So all this counseling also has to be done about the necessary surveillance. So therefore, understanding the inheritance pattern of the disease helps us not only in determining the risk of recurrence, it also helps you in offering appropriate counseling about variable expressivity, sometimes reduced penetrance. Counseling about options of prenatal and pre-implantation genetic testing can be done for the family, and other at-risk family members can be identified to initiate appropriate surveillance and management. Moving on to the next clinical scenario, so this was a 26-year-old third gravida. She is second degree consanguineously married. She had two previous affected children. This is the photograph of the second affected child who had microcephaly, profound global developmental delay, and seizure disorder. And this lady was referred in the third pregnancy at 8 weeks of gestation for prenatal testing. Unfortunately, by the time the family presented to us, both the affected children had died and they had not preserved any DNA samples for either of the affected children. Interestingly, in the history, they said that in the second pregnancy, they had consulted an obstetric specialist for prenatal testing. Unfortunately, the obstetrician had not advised any sort of genetic evaluation of the couple or of the previous child. Rather, she directly advised amniocentesis and fetal karyotyping for the second pregnancy. The fetal karyotype was reported to be normal. The antenatal scans were normal. So she reassured the couple and asked them to continue the pregnancy. But as we know, as we saw from the pedigree, after birth, unfortunately, the second child also was found to be similarly affected. So, why did this happen? So, now if you look at the pedigree, you can see there is second degree consanguinity. The lady has married her maternal uncle, and now two affected children are there, one male and one female. So, what is the most likely pattern of inheritance here? It is actually autosomal recessive pattern of inheritance is the most likely pattern. And then we asked them to show the previous medical records. They were able to show us the MRI brain images of the second child who had passed away. So, as you can see here, the MRI is showing diffuse cerebral atrophy. There are extensive cystic encephalomalacia changes here in the cortex as well as the subcortical white matter. There's thinning of the corpus callosum, there's ventriculomegaly, and there is also extensive white matter T2 hyperintensities. So, based on all of this, we suspected the possibility of isolated sulfite oxidase deficiency or molybdenum cofactor deficiency. Now, this is an autosomal recessive disorder. So we expect that both the parents, the partners, will be heterozygous carriers for the disease-causing gene variant. So even if we do not have DNA samples of the affected deceased offspring available, we can directly go for exome sequencing of the couple with this possible differential diagnosis in mind. And that was what was done. And both were confirmed to be carriers of SOX gene mutation. And SOX codes for sulfite oxidase. So, SOX is associated with sulfite oxidase deficiency. So that confirmed our diagnosis. And now that we have the exact mutations identified, we can do appropriate prenatal testing. So this is how prenatal testing should be done. You have to identify the exact pattern of inheritance, the risk of recurrence, the exact diagnosis, the exact mutation, and then targeted testing has to be done for that in the prenatal sample. Directly doing some testing which is not relevant would not help you at all. The couple had undergone karyotyping in the second pregnancy. Karyotype was normal, and obviously karyotype would have been normal because this is not a chromosomal disorder. This is an autosomal recessive disorder. So we now know that the condition is an autosomal recessive condition with a 25% risk of recurrence in each offspring. So accordingly, prenatal genetic testing was suggested to the family. They underwent the amniocentesis and targeted variant testing of the SOX gene. Fortunately, the fetus was found to be heterozygous and not affected. So please remember, prenatal pre-implantation genetic testing for recurrence in subsequent pregnancies should always be done through targeted mutation analysis for the variant which has already been identified in the index child. And if the index case is no longer alive, you can identify disease-causing mutations by testing of the parents. So for autosomal recessive disorders, we know that both parents will be heterozygous carriers. So you can identify the mutation by testing them. Whereas for X-linked disorders, we know that the mother will be a heterozygous carrier and you can identify the mutation by testing the mother. Yes, of course, the mutation was de novo in the proband. Moving on to the next clinical scenario, 29-year-old female patient. She was operated for bilateral pheochromocytoma, medullary carcinoma of the thyroid. History revealed that there was history of death of the father at 45 years of age due to some malignancy, possibly a bone metastasis. Beyond that, so they knew that the father had some form of malignancy, but they did not have the details. But with this pattern of this lady having pheochromocytoma and medullary carcinoma of the thyroid, we are very strongly considering the possibility of multiple endocrine neoplasia. So this is what the pedigree looks like. So father was most likely affected, this lady is affected, so quite likely to be an autosomal dominant condition and very likely to be a autosomal dominant condition associated with malignant predisposition to malignancies. And given the pattern of malignancies, MEN, multiple endocrine neoplasia, is the more likely possibility. So on testing, Again, here we went with the NGS-based familial cancer multigene panel testing, and the lady was found to be heterozygous for a pathogenic variant in the red gene. And this is associated with multiple endocrine neoplasia type 2A. So now we know that because this has an autosomal dominant pattern of inheritance, there is a 50% chance that each individual of an affected parent could have the mutation. So here, is there any role for pre-symptomatic testing for siblings and children? The answer is yes, because we do have pre-symptomatic intervention and surveillance available for men to A, and you can do very effective pre-symptomatic intervention to reduce the risk and improve the survival chances of the individual. So after appropriate and detailed pre-test genetic counseling, the testing was done. Fortunately, the lady's children actually were both negative for the mutation, because there is a 50% chance that the offspring may not get the mutation. So fortunately, both of her children did not have the mutation. But unfortunately, when they presented, the brother was told to be asymptomatic. But after testing, we realized that the brother also had the same mutation. And unfortunately, the brother's daughter also had the same mutation. So now, how can we use this information? We have to then initiate surveillance for all these affected family members for medullary carcinoma of the thyroid. There are specific surveillance guidelines for all these familial cancers. So for men to A also, we have specific guidelines for surveillance of medullary carcinoma of the thyroid, for pheochromocytoma, for parathyroid adenomas and hyperplasias. So if you look at this, the mutation which was identified in this family actually falls into the high risk category, where there is a risk of aggressive medullary carcinoma of the thyroid, and there is a role for prophylactic thyroidectomy even below 5 years of age. So now that we have clearly understood and done the testing, we can initiate appropriate surveillance and prophylactic surgeries for the sibling of the proband and also for the sibling's daughter. So, in fact, the younger sibling surveillance was commenced, and unfortunately, at the very first surveillance itself, he was found to have medullary carcinoma of the thyroid. Early surgical intervention was possible for him. And for the niece, sorry, not the nephew, surveillance and prophylactic thyroidectomy was also suggested. And they actually took some time to decide about this. But after about 3 years, when the child was about 8 years of age, they went for prophylactic thyroidectomy for the brother's daughter also. So this shows us how understanding the inheritance pattern helps us in counseling about appropriate pre-symptomatic testing for at-risk family members to initiate all the appropriate interventions and surveillance. And generally, if there is no intervention or treatment available for later onset disorders, we usually don't do pre-symptomatic testing for children. But if you have possibility of the disease appearing in childhood, and particularly if you have good intervention modalities available and proper surveillance available for such conditions, then pre-symptomatic testing should be done in the pediatric age group also. Moving on to the next scenario, a 15-year-old boy was referred following diagnosis of vortex keratopathy. So this is a sort of a corneal lesion. And on examination, he was found to have multiple skin lesions. I'll come to that. And his other investigations were all normal except his 24-hour urine protein, which was found to be mildly elevated. When we took a detailed family history, we found that there was history of CVA, hypertension, and chronic kidney disease in two maternal uncles. And the maternal uncles were also called for detailed clinical evaluation. And you can see they have multiple skin lesions, and these are what we call angiokeratomas. This was there in the 15-year-old boy also. And with this pattern of angiokeratomas, history of CVA, of renal disease, vortex keratopathy, all of that put together, the most likely diagnosis is something called Fabry disease, which is a lysosomal storage disorder caused by deficiency of the enzyme alpha galactosidase due to mutation in the GAA gene. So if you look at the pedigree, what does this remind you of? It is a very typical X-linked pattern of inheritance where all the males are affected and the proband has affected maternal uncles with carrier mother and carrier grandmother. So this is very much suggestive of an X-linked pattern of inheritance. So because we knew this, we were able to do evaluation and surveillance for all the other at-risk males in the family. And Fabry disease is a condition where even ladies can have manifestations. So even the mother and the grandmother were evaluated, and both of them were found to have mild proteinuria, and the mother also had vortex keratopathy. And further, of course, confirmation of the diagnosis was done by enzyme assay of the alpha galactosidase enzyme, which clearly showed the deficiency of the enzyme. And then, fortunately, Fabry disease actually has enzyme replacement therapy available, which is very expensive, but we were able to procure it through the charitable access program of the pharma company. And this was initiated for this boy at 16 years of age, and he has been on regular ERT for the past 9 years. Because we have been able to initiate the treatment early for him, fortunately, he continues to have only mild proteinuria, but no further progression of disease. The maternal uncle also, one of them, they were able to procure ERT through the same charitable access program, and he has shown a significant improvement in quality of life, although he continues to have chronic kidney disease. So, medical records of the family members should be obtained wherever feasible. And please remember that detailed family history is very important because it can help not only the index patient but also help to identify other affected family members and do appropriate treatment for the all the affected family members. And finally, the last case. This is a non-consanguineous couple. The first child was affected with Duchenne muscular dystrophy. At that point of time, there was no similar family history because we know that almost 70% of affected individuals have deletions or duplications of exons in the DMD gene. MLPA is the first line test which is preferred. That was what was done, which showed deletion of exons 46 to 49. If you can see the deletion of the exons here in the proband. Mother's MLPA was done, which was told to be normal. Which is normal. And so she was told that she's not a carrier. So unfortunately, the gynecologist actually suggested that there is no need to undergo prenatal testing since the mother is not a carrier. But what happened? Unfortunately, the family came back after a year to the gynecologist, and the baby was born by that time. And the baby was showing some early signs, not after a year, sorry, after about 2 years, when the child was evaluated. The second child was also a male child, and this child also showed some early motor developmental delay. And when the CPK was done for the second child, the child also showed a very highly elevated CPK. So why did this happen? Why is it that although the mother is not a carrier, the second child was also found to be affected? So this is where this concept of gonadal or germline mosaicism comes in, where the mutation is not present in somatic cells of the parent, and therefore it will not be detected in the blood DNA testing. It is present only in a proportion of the gonadal cells. In the case of X-linked disorders, in the mother. In the case of an autosomal dominant disorder, it could be present in either the father or the mother. But we have to understand that this phenomenon is a possibility for all X-linked and autosomal dominant disorders. The first affected child is often mistaken to be a sporadic case due to a de novo mutation. But because of this gonadal mosaicism, that can be a recurrence in the subsequent pregnancies. In fact, 12 to 15% of cases of DMD are due to gonadal mosaicism. Therefore, prenatal diagnosis should be offered to all mothers with one child affected with DMD, even if they test negative for carrier status. So, in fact, when they came back with a third pregnancy, MLPA was done for the CVS DNA, and the third pregnancy also, unfortunately, was found to be affected, and the pregnancy was terminated. So, thorough understanding of the concepts of basic genetics and principles of inheritance are essential for accurate genetic counseling, and referral to a clinical geneticist is important for appropriate genetic testing and counseling. So, it is important to understand, although these concepts may look very basic, it is very, very relevant to clinical practice because unless we as clinicians understand these basic concepts thoroughly ourselves, we will not be able to explain all these adequately and appropriately to our patients. So I'll stop with that and thank you very much. Thank you, sir, for this opportunity. We'll be happy to take questions.
Yeah. Thank you, Dr. Prajna. There is one question from Dr. Shifali. Ma'am, if clinical features match more with VUS in genetics report rather than with pathogenic variant, what to do in that case?
So, when we so we'll be having another session on interpretation of variants and what we should do if we encounter a variant of uncertain significance. But generally, variant of uncertain significance means that at the present time, we don't have sufficient information about the variant in the variant databases in scientific literature. So here, what we do is we can go to a certain extent of looking for additional levels of evidence. So one level of evidence is we do a rephenotyping. We check if all the clinical features of the patient are clearly matching with what is expected for that genetic disorder. Second thing, we do additional relevant investigations. For example, if you get, for example, the Fabry disease example I gave you. Now, if we had done molecular testing first, if we had found a hemizygous variant of uncertain significance in the GA gene in the proband, one of the simplest things that we could have done for corroboration would be enzyme assay and document that the alpha galactosidase enzyme level is low. So that is the second thing that you can do. Additional relevant investigations for corroboration of the diagnosis. Third thing, we look at the segregation pattern in the family. So again, going back to the same Fabry disease example, if we had found the VUS in the proband, we would have checked it in all the affected maternal uncles, in the unaffected maternal uncle, in the carrier mother, and so on, and confirm that the variant is present only in all the affected individuals and the carriers and not present in the unaffected individuals and non-carriers. So that is one more level of evidence that you get, which we call segregation pattern. So quite often when we do all of these additional levels of evidence, if we get the variant of uncertain, so there are some specific criteria. I was telling you about the ACMG criteria. So when we add on these levels of evidence, sometimes these variants of uncertain significance get reclassified as likely pathogenic, and then we can consider them. But in many cases, even after all this additional evidence, the VUS may remain a VUS only. Then the only thing that we can actually do is we can tell them that overall the pattern seems to match, but at the present moment, the diagnosis is not confirmed. The patient needs to be under regular follow-up. We keep the family under follow-up. Every 6 months to 1 year, we keep rechecking status of the variant. Most of these databases keep getting updated. So over time, as we keep reanalyzing, we may find that the variant has gotten reclassified as likely pathogenic or whatever over a period of time. So this is how we deal with VUSs.
Thank you, ma'am.
Priya, you want to add something to that? Okay.
No, ma'am.
Thank you.
Generally, that is what we do. And nowadays, we are getting newer techniques like RNA-seq and others, which we can try and do once those become more easily available, and we can try and opt for it. So for
Yes.
VUS classification, RNA-seq is something we're really looking forward to as a diagnostic modality.
Yes, so ideally we should be doing functional assays, RNA-seq or even cell line based, animal based studies and all that. But of course, it is not practically possible in the clinical setting for majority of the scenarios.
Thank you, ma'am. There is one answer for the question of Dr. Priya by Dr. Sentler. Myotonic dystrophy.
That would be correct. That would be my request.
Yes.
Those who had participated, they are very serious about genetics. So one thing is clear, ma'am. We know as a pediatrician, we know that we have a lot of reference for complicated diseases, rare diseases, metabolic disorders, and unknown diseases where we cannot diagnose. But after listening this third episode, I think this prenatal genetic counseling or prenatal genetic evaluation in future, in very near future, will become as common as antenatal ultrasound or antenatal testing. Maybe I think almost every second child, maybe every second pregnant woman may come to you for genetic advice and evaluation. So it's really very interesting. And as a pediatrician, I request our pediatrician, whenever you think there is a necessity of geneticist advice, or you suspect, or you think there is something to do with genes or genetic disorders, do not hesitate to refer the mother or child or the family member to our well-learned geneticists. We are fortunate to have good geneticists in Hyderabad and across India. So the best part of pediatric clinicians is to refer the cases which are unknown or rare or complicated or anomaly. And this is the conclusion. And very excellent presentation by both the speakers with very attractive and colorful slides. And I'm surprised both the speakers didn't get hyperglycemia even after speaking for 90 minutes continuously. Very exhaustive, but very impressive, very learning experience. And my sincere thanks before I give it to our dynamic treasurer who makes the comments and word of thanks. I really appreciate to be with us, avoiding a most awaited family breakfast with your family members. I sincerely thank and indebted for Dr. Prajna Ranganath and our team. Thank you one and all, and over to Dr. R.S. Krishnan.
Thank you,
Yeah,
sir.
thank you. So I'm taking that quote, ma'am, which you had kept in the last slide, saying that you don't talk about it when you don't know well enough. I'm sure by the end of 2025, most of the IAPians will start talking about genetics because your sessions are so informative. It's almost as if we finish the first year of MD genetics in this year, thanks to Dr. Bhaskar and of course to Dr. Pragna and the team. Thank you. Thank you for sharing your insights. And it's been a very informative session, very insightful. And we look forward to now the next session. It's actually a pain for some of us to wait for 1 month to see the next episode. But I'm sure in the next 1 month, we'll have more PATS activities coming up. We've had one oration of Dr. Deshpande at Ramagundam yesterday, and we have another oration of PATS which will be coming up, along with the pediatric pulmonology workshop and more academic activities in the month of March. I know the sun will shine and we'll all get chance to meet each other. So please participate in all the PATS activities, and we look forward to joining you all on an online webinar very soon. Thank you, everyone.
A small humor comment. Since we are hearing so much about variants, deletions, between two names, there are few deletions and few variants between the faculty of Dr. Prajna and Dr. Priya. Please laugh and relax. What I was saying is, in spelling, some deletions and some variants, if they mix up, the names become the same.
Yeah.
Thank you.
Yes, sir.
Thank
So
you.
there's a
Thank you.
disclaimer here. Priya and I are not sisters. We are completely
Madam
unrelated.
Madam is my teacher. Everything I know in genetics is because of Ma'am, and I'm very grateful to have met her in my life and learned so much from.
That's wonderful that you both share the same profession as well as the surname.
Yeah,
Entire
that's just a
IAP,
coincidence.
IAP of Telangana state have a lot of regards and respect for Dr. Prajna for her commitment and for her hard work at your center of excellence, that is NIM. So thank you one and all, and
Thank you. Thank you, everyone. We look forward to joining you at the next webinar. Thank you.
Thank you, sir.